Good evening, everyone. Thank you all for joining us for this webinar, which is our final presentation in our series on alcohol and other drug use, funded by the Sydney North Health Network. I would like to begin by acknowledging the traditional custodians of the land and paying my respects to elders past, present and emerging, and also extend that respect to other Aboriginal and Torres Strait Islanders who are here with us today. My name is Christina Morell. I'm a Senior Research Fellow and Program Lead of Treatment and Translation of Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. And I had the very great pleasure of co-facilitating this webinar tonight along with Professor Catherine Mills, which will be presented by Associate Professor Renee Batoon. Renee is an Associate Professor at the University of Notre Dame and an internationally recognised expert in smoking cessation. She's worked in the field for more than 30 years and is an inaugural member of the International Society for Research in Nicotine and Tobacco. She started one of the world's first smokers clinics in Sydney in 1979 at St Vincent's Hospital, and she's also the founder and editor-in-chief of the International Peer-Reviewed Journal of Smoking Cessation, as well as a clinical consultant to national and state health facilities, hospitals and Indigenous health groups, and we're delighted and extremely lucky to have her here with us tonight as she presents part 2 of our topic on smoking cessation, how to manage smokers. So before we begin, I'd just like to draw your attention to the Q&A and chat buttons on your screen. Please feel free to click on these at any point and type in any comments or questions that you have throughout the webinar tonight. We will have time at the end for time to go through these questions and comments. If you happen to experience any technical issues during the webinar, you can call the technical support line with the details that are on the screen, or visit the Zoom support webpage and chat with an online staff member. We'll also be putting this information into the chat boxes so you can find it if you need to during the presentation. We are also recording tonight's webinar, so if you'd like to view it again or download the slides as handouts, you can access them at the website that's listed there on screen. We'll also put this up at the end of the talk tonight. And lastly, if you're joining us live, you can complete the CPD evaluation at the end of the webinar if you'd like to claim CPD points against this activity. And now I'd like to hand over to Renee to start us off with a recap of what was covered in part 1 of this topic at the end of last year. Thanks, Renee.
Thank you so very much. I'll just do the right thing and click on do what I'm supposed to do to enable us to be able to view my presentation. Hopefully that's correct. Is that, Christina?
Yes, that's right.
Perfect. Lovely. Thank you so much. So I've prefaced the presentation about how to manage smokers, and I like to use that word manage and management rather than using the word help to help smokers quit. So I'm trying to change the language to be less intimidating, and I'd like to sort of quit using the word quit if we can, and have a think about how that might change your particular way of addressing this with your patients or clients. The revision is really to do with looking at how we understood from my last presentation the neuropsychosocial determinants, how various effects from, say, liver function might affect how you metabolize nicotine, reminding you that there are fast metabolizers and slow metabolizers, just like other substances, alcohol being one of them, for example, that if you're a fast metabolizer of alcohol, you need to drink more, literally, to get the same blood alcohol level, and the same goes with nicotine. If you're a fast excreter of nicotine and you're born with that liver enzyme CYP2A6, and it's a fast functionally active enzyme, then you're going to need to smoke more. And people aren't really quite aware that there is that relationship. This has nothing to do with your lifestyle or your motivation or your stressors in life. It's a liver function thing. So keep that in mind when people, smoke a lot, wake up in the morning, smoke very quickly first thing in the morning, drag really hard on cigarettes. Think more of their liver function than you have in the past. I want you to remember that, because there are other determinants like how you metabolize pharmacotherapies. Some do it better than others, and to their active ingredients, and I'll address that in a few minutes. Such that might help you better decide what pharmacotherapy might be more appropriate for one patient over another. And it's really just to remind you that because of these variations in individual smoking profiles, the treatments are not a one-size-fits-all anymore at all. And so you can better, as I said, perhaps develop your strategies with patients using the language management, because that's what it is. It's less intimidating and it is more medical. If you want to use that medical model, you wouldn't ask a patient, for example, who is hypertensive, would they like to have a antihypertensive? If you're taking their blood pressure, you might say, this is something we need to address. And this is what I'd recommend you do. Not, would you like to do something about your smoking? And if they say no, move on to something else. That's not appropriate anymore. So we're trying to deal with the language that we use and look at behavioural changes that are evidence-based too, which I'm going to discuss today too. We also looked a little bit last time about how you assess a smoker. We know that time to first cigarette is terribly important. If you're a quick metabolizer of nicotine, you wake up in the morning having excreted most of it. It's in your, as cotinine, which is its metabolite, in your urine. And so you're going to need to smoke pretty well first up. Why do you need to do that? Literally, nicotine has become a neurotransmitter substance that's usurped, that's the term, usurped acetylcholine. And so these nicotine acetylcholine receptors are really activated hugely and preferentially by nicotine. So that becomes actually a neurobiological dilemma for smokers who wake up in the morning empty. They tell you, I just cannot. They don't tell you I can't neurotransmit, but they'll tell you I can't function without it, I can't concentrate, I'm not doing well, nicotine gets my motor rolling. And that's about right. You can tell them it's a bit like the oil in the motor, gets the motor started. And so time to first cigarette is a very important and imperative question we always ask. How soon after you wake do you have your first cigarette? We like to ask them about their quitting history. What's it been like? Have you ever tried to not smoke? Did you try, say, nicotine replacement therapies? How did you go? Did you ever try bupropion or Zyban? Did you ever try Champix or varenicline? How did you go? Because when they've had these, and invariably have had pharmacological failures, that's a flag for you. For example, we know that there are whole ranges of nicotine blood levels. Some people require a great deal more than others. So we learnt that in our last presentation, that psychiatric patients might have 3 or 4 times the amount of nicotine in their bloodstream than non-psychiatric patients. Why is this so? They're using nicotine to help neurotransmit. But if you're using nicotine replacement therapy, you're not going to be able to replace that quantity that they would have extracted by smoking hard on a cigarette. So NRT often isn't sufficient, not enough of it. And that's becoming evident with a lot of our patients. And I'll talk to you a little bit about that later. The family history is terribly important too. Smokers breed other smokers. It's not just this family trait that everybody's doing it within the family, and you saw mum and dad smoke and they've been role models, and there is that cultural or environmental stimulus, but there's also this response to nicotine. We know that not everybody is a responder. Not everybody goes wow with a cigarette the first time they ever have one, and we know that kids do. There are some who do and some who don't, and that seems to be the heritability of that nicotine acetylcholine receptor subtype. So there's a lot of heritability in nicotine addiction. It's more heritable than alcohol dependence. Just to remind you, it's a highly inherited trait, highly heritable trait. The environmental context, as I mentioned before, does matter. If there are other smokers around you, so your environment, the culture of smoking, everybody smoking, you've never seen anybody in the family not smoking, then in fact it's normalisation for you or at work. So these contexts actually matter. And of course, if you're grown up in a home where nobody does it and it's not around you, and there are areas in Australia now where whole suburbs are no-smoking suburbs, where you're fined if you smoke on the footpath. Lane Cove, for some of you might know this already, Lane Cove is a place where most people don't smoke. In fact, it's a suburb where smoking on the footpath is banned and you're fined for it. And Lane Cove, for those who don't know this, has one of the lowest smoking prevalences in Australia. How is that for interesting? So not only are the well-heeled and the well-educated of this particular area, and the Northern Beaches, some of you might know this, some of the lowest smoking prevalences in Australia, because socially it's highly unacceptable, and the environment is such that it's considered to be really in front of children, out on the street. We'd like that, of course, to be everywhere. We can't impose fines everywhere, but we'd like that to be everywhere. This whole notion that kids don't know what a smoker is because they've never seen one, which is ideal. I want you to, when you're thinking about talking to a smoker about their medical history, psychiatric for reasons I just mentioned, is it self-medication? There are relationships between mental illness and smoking, and I mentioned last time there are significant now studies showing that mum smoking in pregnancy, children exposed to nicotine in their adolescence are much more likely to have mental health concerns as they age, to the point of a relationship now really quite significant between schizophrenia and the mums of those schizophrenic patients smoking during pregnancy, and suicide and suicide ideation in children exposed to nicotine, either in pregnancy or in their early adolescence, a higher risk of suicide and suicide ideation. So these are not small matters. Nicotine is evidently toxic to the developing brain, and this is really becoming the topic for these coming years, the toxicity of nicotine in development. I mentioned also that women metabolize nicotine a little faster than men do, so there is a gender difference, and ironically, if anything, in pregnancy even faster, as they do many other substances, metabolize it faster. So the irony is that if you're going to consider NRT in pregnancy, you need to give them more, not less, NRT in pregnancy. So that's usually counterintuitive to many people. I'm not saying that pregnancy is a comorbidity, but I just wanted to remind you of comorbidities, especially other substances people are using, concomitant medications, smoking, not nicotine. Smoking affects caffeine levels and alcohol levels, insulin levels, antipsychotics. You probably know well about the clozapine effect from smoking, lowering the levels of clozapine if you're a smoker. I want to remind you that in amongst the many medications that are affected are not just clozapine, olanzapine, warfarin is affected by smoking. That is, it makes it weaker. And to remind you that we have now added methadone to that. So if you're a smoker, it makes methadone weaker. What happens when you quit? All these substances become stronger. So if you're on the same dose of warfarin and you now quit smoking, your warfarin levels, your INRs, are going to change. Antipsychotics are going to go up. You know this, I hope. Alcohol levels go up. So people claim, they say, I'm a cheap drunk since I've stopped smoking. And I just wanted to remind you of those things. And methadone too goes up if you stop smoking. So these medications, substances need to be adjusted down. Mostly it's adjusted down, and we have good references for that on New South Wales Health. There's a particular website called the Tobacco Toolkit, and it's all in there for you to have a look at. So I'm just reminding you that numbers of cigarettes smoked per day are not always that relevant. I just wanted to remind you that I'm hoping that you can. I just want to apologise if things go pear-shaped here. I'm presenting this from Broken Hill. Sometimes the internet access isn't always great, so hopefully it's all going well. Um, just daily smoking and how many a day that you actually smoke. Numbers per day. It's not irrelevant. It's just less relevant. Don't get too fussed about how many people smoke a day. It's how they smoke. Do they drag hard? Do they, smoke the whole cigarette? This is called the topography of your smoking. Is it better to smoke? I heard this today. I'm working today in Broken Hill in our Indigenous population groups, and people say, that a lot of mythology about the mild cigarette, the roll your owns are better for you. It's less adulterated by chemicals. This is all not correct. This is all myth that we need to debunk. Debunk the myth that rolling your own is somehow better for you, that the tobacco in it is less manipulated. None of this is correct and none of it's true. So just a revision about it's harder to quit. People who smoke within 30 minutes of waking up, and we always ask that question. They've tried many times and are very symptomatic when they've tried. They've used NRT in the past. They've smoked while they're using NRT, which, by the way, is safe, but they don't know that, and they think, well, I've read the packaging, or my doctor's told me, or my friend has told me this is serious, you're going to overdose with nicotine. But these are flags for you to tell you usually that that's not enough pharmacotherapy, not getting enough. They've not had very good experiences with quitting in the past, or made an attempt, and they're likely to be fast metabolizers of nicotine. This is hard to tell. How do you know? You can do some assays, but they're not handy and very helpful for most people, easy access to it. But you can certainly ask, as I said, time to first cigarette is a really strong indicator of that. The interesting thing for us is most people want to stop smoking. They want to do something about their smoking. It's just they can't get over the line. And this decision to do something about it is often corrupted by the addiction itself, which is manifestly a sign of addiction, not being able to do something that you really want to do and doing something contrary to your best interest. Remember, we've got smokers who do this no matter what, no matter how much it costs, no matter how bad it is for their health, no matter the social or physical implications. That defines an addict. They're doing it anyway. So here's some tips for talking to smokers. We certainly like to talk to them more about the biological basis for this. They don't know much about, they don't even know nicotine's like working in the brain and how it works. You don't have to give them the details, but the more they know about it, the more appreciative they are and understand why maybe they have had problems with this and other people haven't, because there is a range of this and that it is complex. I don't know about you, but we try not to nag our patients. A paper on nagging about smoking, because we know it's counterproductive. The more you nag, the more you say, are you doing something about your smoking? Have you quit smoking? The more you do that, the more you antagonise the patient. And ironically, you can imagine they go out of the room thinking, bugger this, and they'll smoke more. And they do. So there are good papers on showing it's not a good idea to nag. So we've got to be a little bit more subtle about it, if you want, a little bit more non-judgmental. As I said, changing the language would be great. If you could change the language to manage and tell them, we know that this is all complex. This is not a one-size-fits-all. So they say to you, well, my wife did really well, or my partner did really well, or somebody down the road did really well on one form of pharmacotherapy. How come I haven't done well? You just need to explain. It's, if you want to explain it like an antibiotic for a bacteria, we need to make sure it fits the right person, the right problem, and say it like that rather than you weren't motivated, or it wasn't the right time. So often people are doing the right thing, is just not the appropriate treatment. There's interest in quitting and asking that now, ironically and interestingly for me, because I've been talking about the stages of change model for decades now, literally decades, and saying that it doesn't really fit appropriately for smoking and smoking cessation and addictions in general. And it seems now that's been validated with quite a lot of studies showing that if you ask a patient, where they are in the stages, it actually doesn't help them very much. And certainly asking if they're interested in quitting, they vacillate anyway between, yes, I want to do something today, and no, I don't want to do anything about it tomorrow, to actually having their decision making about this, as I mentioned earlier, corrupted by this, by their urges to smoke, by the disquiet they have, the withdrawals they're in. These are drivers to, on the one hand, wanting to not do something about it, and on the other hand, not doing anything about it. So how do we change the language? We need to sort of address this a little bit differently. We can say that there's good behavioural interventions, things that we can recommend that they do that is evidence-based, and there are good pharmacotherapies, and reminding them that there are ranges of this. Counselling obviously helps. It's very difficult for everybody to be able to be skilled in this counselling, but I will give you some tips a little bit later on about what you can say within, minutes or seconds of seeing somebody, some important tips that you can say that will help immediately with managing their smoking. Of course, we want to help them quit. I don't want to say that's not our agenda, but we don't have to say that to them. We're talking more about managing their cravings, managing their symptoms of withdrawal, and easing them. I heard this recently said, and I thought it was a wonderful expression. Instead of saying cold turkey, can we say warm turkey? Just getting off it, but perhaps a little less stressful for you. That's really our agenda for all of us. In terms of pharmacotherapies, I've got here, these little bottles of miracle cures. There's a lot out there. There's a lot of anecdote. There's a lot of N=1, and not a lot of evidence to support. And I want to remind you that there is not a lot of evidence to support in science hypnotherapy or acupuncture for these particular problems. It doesn't mean that they're not successful or helpful for perhaps relaxation, perhaps other components. But in terms of managing withdrawals, no real evidence. Psychotherapy, no real evidence. Counselling for, say, negative affect counselling, no real evidence. The self-help books, again, people perhaps distraction reading it, but in terms of actual evidence to support, not a lot. So I've got a lot of these listed here for you to understand. For example, for us, one of the most important things that people, or myths I'd like to debunk, is cutting down. Individuals, of course, people think if I cut down, it's better than, if I smoke 5 a day, it's better than 50 a day. And that sounds intuitively correct. However, that is not correct. People may compensate by smoking and inhaling deeper. And I saw a patient today doing exactly that. They very proudly said, which is fair enough, I'm only smoking 10 a day now, and I used to smoke 30. And I measured their carbon monoxide, expired carbon monoxide. It went up. They couldn't understand, why would this go up when I'm smoking less? Because what you're doing is dragging harder on the fewer cigarettes you smoke. And ironically, the fewer you smoke, the more you're going to compensate doing that. Unfortunately, that cigarette becomes more rewarding. So if you have a 2-hour gap between cigarettes, you tend to smoke the next one really hard and get a bang for your buck. If you chain smoke one after another, you don't get those hits, those shots, because the decay is quick. And then you have another one and another one, and it sort of goes up and down. But if you let it drop really low, then you get a shot of nicotine, which is very reinforcing. Remembering that you get dopamine, serotonin, beta endorphins, get a big bang for your buck when you have less cigarettes. So that's the irony of cutting down. Unless you're going to cut down to cut out, and that's unusual, very unusual. As I mentioned earlier, weaker cigarettes, milder cigarettes, again, people do exactly the same. Not only are they worse for you, they're definitely worse for you. So you're dragging much harder to get your required nicotine content. So the evidence-based pharmacotherapies that we do have today are the evident ones for us, all the NRTs of all types, and hopefully you all noticed in the beginning of this presentation that I have no conflicts of interest with the pharmaceutical companies. Not on any of their boards, don't take a cup of tea from them. Quite seriously, no hospitality in any way. And evidently not from the whoops, that was a slip, the tobacco companies either. So just mention that simply because I'm a strong proponent of using pharmacotherapy. Prior to the 1980s, we had no pharmacotherapy at all. So I come from an era where we had nothing to give patients. Then we got things like nicotine patches in the 1980s, 90s, 1980s. We got gum in my hand, the first nicotine gum ever in Australia, and it was fantastic. And so we were terribly grateful to be able to give our patients something that actually helped, that's evidence-based, it's been trialled properly, and these are very good first-line treatments. Now, having, we think, treated those who could have quit using those pharmacotherapies, now looking at more difficult cases, people who need more, we know that combining pharmacotherapies are better than the treatments on their own. So combination treatment is now the go from most of our patients who are still smoking. So as I said, I believe we've picked the low-hanging fruit. Those who could have quit in a sense. In some communities, certainly that's the case. So those hardcore, if you want, are there hardcore people who are finding it very difficult? If we give them combination treatments and we do this well, we can get them off smoking. It may take a little time, and that's all right. I'm not lazy. I'm really keen to get people eventually off smoking altogether, and it may take some weeks, it may take a month, it may take longer. That's fine, but that's our strategy. More pharmacotherapy for longer and stronger. The second-line treatments like nortriptyline and naltrexone are not registered for use in smoking cessation, but I'm mentioning them because there are people who do prescribe them, and I just wanted to mention that there is some evidence that they're successful. In some countries, in Southeast Asia in particular, nortriptyline is used a great deal. It's off-label, it's cheap and easy, and pharmacists can prescribe it. And therefore it's used very readily with great success. So I'm just mentioning we wouldn't do that here in Australia. There are obviously side effects and contraindications that we would not potentially use nortriptyline so readily. So as I mentioned, combination therapies are really more effective than single use, and currently, if you want my opinion is varenicline is currently the best pharmacotherapy for smoking cessation. For me, if it was me, I'd be on it. And are there any contraindications? Pregnancy is one of them, and nothing else really. So there's no real side effects, and I'll talk about that in a second, about side effects, the concerns people have had about side effects for any pharmacotherapy really. So what's the right treatment for my patient? If you're thinking about perhaps, you should decide, I think. I don't think it's a patient's choice. Can I say that? Am I allowed to say that? I don't really think patients should choose, because they don't really know the complexities of how you metabolize these things, what their past histories have been with using it. They tend to go on anecdote from other people, and it doesn't necessarily mean that that's going to be successful for them. You may discuss it, but I think sometimes you're better off deciding what's the most appropriate for them. And their past usage, if they've used it properly but they haven't done well, then, for example, in varenicline, there's no point in reviewing it, doing it again. And certainly with bupropion, there's no point in doing it again if they haven't done well and used it properly in the past. Remember, there are familial traits in treatment success. So ironically, if my sister or my family member, right, my biological family member, did well on one sort of pharmacotherapy, there tends to be a familial trait in that. So I was talking about the anecdote, but that's more the gossip part, I mean. I certainly know that there are familial traits in outcomes. Keep in mind the age and the gender of the patient. The older you are, the better you do, which sounds, again, counterintuitive. You've had a longer history of smoking, but you might do better. Smoking cessation tends to be age dependent, reminding you that women metabolise nicotine a little faster, might need more NRT. So that all these things matter. What about the cost concerns? There are everybody, and I need to remind you about this, everybody is entitled to prescribed NRT, and it's on the PBS for everybody. Everybody is entitled to a subsidy. It ranges in what that subsidy is, but it is, and I want to remind you of that, it's very expensive if you buy it over the counter, but not if your patient has a prescription for it. What are the contraindications for NRT? If you're a smoker, there are none for NRT. In pregnancy, I mentioned bupropion. I certainly mentioned varenicline or Zyban and Champix, contraindicated in pregnancy. What others are there? We'll talk about those in a minute. And do non-daily smokers use NRT is something to consider too, because I certainly do that. You know, I've got a classic case of a Friday nighter. She just smoked on Friday night when she was drinking. We put a patch on her in the morning and she didn't smoke on Friday night when she was drinking. So just for one day a week. So it can be done if you think this through. So a little bit more about NRT. It certainly relieves cravings and withdrawal symptoms, and certainly replaces all the, if you can, replace all the nicotine that you get from these, from your cigarettes. That's the trick. It's called nicotine replacement therapy. And so replacing what your nicotine levels are is the trick here. We certainly know there are no serious side effects. People complain about a whole lot of things that are really not related. For example, people complain, I put on a patch and I can't sleep at night. We apply patches at night before going to sleep because patches, for example, take hours to peak, not days, but hours, and certainly not minutes. So when you apply one, it may be 3 or 4 or maybe 6 hours. If you're a bigger person, it might have to diffuse the nicotine from the patch into the bloodstream. It may take many hours. So we like people putting these on just before they go to sleep so that it peaks in the morning. So think of it like that. This is a recommendation we've had for some long time now. I just wanted to remind you of that. And the other reminder is of their caffeine levels. If you ask about caffeine, which I do every time I speak to a smoker, how much coffee do you drink? If you remember that when they're not smoking or reducing even their smoking using NRT, the polycyclic aromatic hydrocarbon effect, that enzyme induction is going to be reduced, their caffeine levels will go up. And if you ask them how much coffee are you drinking now or caffeinated drinks, that may explain why they cannot sleep at night. Nothing to do with the patches. Ask them about caffeine use, please. We certainly know that that's just some of it, that for example, their stressors are managed better. We like to have patients thinking about this in advance, thinking about how can I use oral NRT when something unpleasant occurs. We recommend it strongly. We recommend a lot of it, and we recommend it longer. The longer you use this, the better the outcome. That's our view in these particular difficult cases. Patients who've done well but cut short their treatment unfortunately relapse. So I'd like smokers to learn how to behave. That's how I put it. I want you to learn how to behave without a cigarette. And that takes time. It takes months, not days or weeks. So once you've not smoked, that's not the end of it. Keep going and let life go on, and you learning how to behave without smoking. I'd like to see people on it for 6 months, frankly. Some of our patients, they need it that long. It doesn't mean they need a lot of it. It just keep going using it, and it'll wear off. You'll wear off it. which is sort of an interesting way of putting it. Don't force them to stop using it. Whatever you need, you go with the flow. That's how I put it. It's these NRTs are approved by the TGA in pregnancy, so don't be too fussed or concerned about it in pregnancy. Again, we would rather mum quit smoking without it and manage her smoking without any of it, and the sooner the better in pregnancy. But of course, if that isn't possible and she hasn't managed that, then NRT is certainly safer than smoking. And we don't need, and this is an interesting part of our, I guess, history with using NRTs, that you don't need to wean people off NRT either. This is a complex part of it. For example, the 21-14-7 dosing of NRT, there's actually no evidence for any of that, and we don't need to wean people off. I don't. You stay on the same dose. How is that possible? What's happening? Don't people get withdrawals when they come off the dose of whatever it is? No, they don't. There are changes. I want to remind you, for those who are sceptical about this, that nicotine replacement therapies are not smoking or not inhaled nicotine. The bolus that you get from inhaling nicotine is straight, think of it, it's straight into the arterial blood through your alveolar wall, right? Bypasses the venous system straight to the brain. None of that happens that quickly with any of these NRTs. None of it. Patches are incredibly slow. Hence, I have never in my career, and I edit this journal on smoking cessation, I read journal articles all the time. I've never seen a patch addict. Never, not once. Nobody puts on a patch and goes, that's better, right? Relief. It takes hours to work. So the speed of delivery of nicotine matters. When you're delivering it via the lung, either you're smoking it or you're inhaling it or you're vaping it, it's going straight into the arterial blood, bang to the brain. Bang to the brain makes receptors extremely happy. When you do a slow release, low dose of nicotine, in all of those nicotine replacement therapies, that's what they are, you see less and less, I need an instant, nicotine hit with them. There's a lot less dependence on gums, or there is a hierarchy of this. The quicker the delivery, the more addictive it is. Think of it like that. So patches are right at the bottom, gums are really low and slow. These are all slow deliveries. They keep the receptors happy, but they don't spark them off, if you think of it like that. And that's how I'd like you to think of it. Why do I like patches? I usually like patches better than any of the other pharmacotherapies, especially our mental health patients, because they just need to put it on and forget about it, rather than compliance needing to take it regularly. We put our pharmacotherapies, NRTs, in Webster packs. We like people to know and to remind them that they need to use this a lot, not a little bit. But frankly, if you can put a patch and forget all about it, that's what I'd rather in some of our patients to recommend, because it's pretty easy peasy for them. That's all they have to do. This is just to remind you, and you can see this graph, I'm hoping, where you can see nicotine blood from smoking a cigarette, and this is low actually, reminding you that our patients with mental health comorbidities have blood levels of nicotine could be 40. I want to remind you, nanograms per mil, not milligrams. They're getting nanograms from their smoking. Never get milligrams. Milligrams are lethal. If you're smoking a cigarette 1 to 2 milligrams, you're getting doses, keep in mind, in grams. If you've got a 40 mil nanogram patient and you're giving them, say that is a 16 out, look at the level. We're looking at, can I put this fairly bluntly, this is like peeing in the wind. They're not getting a lot, and it's very slow. This is nothing like the sharp rise you get from a cigarette. So these are slow, low doses. I just want to remind you, compared to what our patients get when they smoke. So don't be intimidated by the concentration. So a patch might say 21 milligrams. There's no way a patient gets 21 milligrams from a patch. They're getting it in nanograms. Look, 10, 12 at most. So it usually doesn't compare to a cigarette. And I wanted to remind you of that. We're often grossly underdosing our patients, particularly our mental health patients, drug and alcohol comorbid patients. We're underdosing them, give them more of it. So we commonly use combinations, and don't be shocked and horrified, but I do have patients with 2, 3, sometimes 4 patches at a time, new ones every day. And so this is not unusual for us to do that, to recommend, because we're replacing nicotine, and it might do the trick. We don't do it all in one go. We might add 1 patch today, next week another one, see how you go. Rather than telling them to quit wearing a patch, let's just wear a patch and smoke. It's safe. See how you go. And I tell them to go with the flow. If you smoke, fine. If you don't, fine. It's okay. And I know that if they smoke on top of using NRT, it's less rewarding. It sparks off receptors a lot less so. We've even got good brain scans to show that. So what we're showing and what we're doing might sound cutting edge to you, but quite evidence-based in terms of the neurobiology of this. As I mentioned, avoid underdosing, night patching I've told you about. If you can do some carbon monoxide, that brilliant, gives wonderful biofeedback to the patient. It's a great motivator, and it guides us about how much NRT to use. Upping the dose, you can see it, as I mentioned before. If you give them some NRT and they're still smoking, their CO readings will have gone down. You give them some more, and it'll go down again, and reminding you not to stop it too early. This is just a quick case study. I don't have a lot of time to cover a lot of things, but this is just to show you a very difficult patient I saw some time ago who had an acute exacerbation of COPD, who was not terribly interested in quitting, and they usually aren't. He had alcohol concerns. He was rolling his own. He smoked, opening his eyes in the morning, and he lived in a religious care facility, which made it very difficult for him because they were always on his case, always. So the first thing I needed to do was educate them about, his carers, about not to nag him, don't be on his case all the time. And they said, oh, look, we've tried patches and he smoked as well. And we thought that was terrible, so we had to come and see you because we didn't want him to die, and it was all terribly toxic and he was going to overdose. And so I had to dissuade them of that, which you need to do sometimes with family, to inform them better. And you can see his baseline carbon monoxide reading was 30. I started on 1 patch a day, and I told him he could still smoke. Shock horror to everybody, the carers, and pleasure to him. He could do that. And you can see in the follow-up, 1 week later, his carbon monoxide reading is going down and he's rolling less cigarettes. I add a 2nd patch. The next week, his carbon monoxide reading is going down. He's chuffed. Everybody's happy. He's rolling less and less until he goes down to none altogether. I took months over doing this, weeks over doing this, took the patches away over weeks, left him on 1 patch for many months, and for about 3 to 6 months. And he's doing fine. No relapsing, and it was a slow process, but that's fine. There's no rush. There was no immediacy, no urgency about any of this, and everybody's very pleased. He doesn't smoke anymore, doesn't use patches anymore, and it's just a nice case for you to have a look at later on, just how you can do this. With regard to Champix, I mentioned it's the best probably of all medications, currently best practice. No known drug interactions. The mechanisms you've probably heard are partial agonist, partial antagonist, and certainly does extraordinary things to pleasure and craving of smoking. Most smokers say they lose interest in it. They'll be smoking and suddenly, I don't know why I bothered. Now that doesn't happen in everybody, and that's there are some genetically determined cell types, brain receptor types that we know have an effect on this. So it's not everybody does well. Some people do better than others. it may not be the best choice for a non-daily smoker at all, but looks like younger do a little bit better and women do a bit better. And if you use it longer, I'm keen on 6 months, and you're entitled to prescribe it for 6 months. In case you didn't know that, you can do that. The safety concerns, I think, has now been allayed, and we're all very pleased to be able to say that there's no really higher rates of any concerns to do with its medication over anything else. Just to spotlight the bottom line there, ask about any unusual mood or behavioural changes and suicide ideation or thoughts in everybody who quits smoking, because we know that these are symptoms of withdrawal in anybody. I mentioned withdrawal, I think, last time, and I want to reiterate that people get very anxious. They get particularly moody, aggressive, depressed, distressed. These are symptoms of nicotine withdrawal. These have predated any pharmacotherapies that we ever had. So I want to remind you of that, and don't assign it to this particular medication. It happened when the patches first came out. I remember the day. People got moody and upset and distressed, and people were saying it was due to the patches. Well, actually not. This is unfortunately due to nicotine withdrawals, and they were probably not getting too much nicotine. It's usually not enough. And be mindful of the fact that these may be withdrawals and not related to the side effects of the medication. That's a bit of a myth that's going around. Just wanted some practical things about NRT, about Champix or varenicline. With nausea, we certainly recommend people need to be reminded to take it with food. We've certainly seen people say, I get vivid dreaming. Remember, the sleep disturbances could be the caffeine, but also to use it a little bit earlier. They're 8 hours apart, tablets, when you're taking 2 at a time, the 2 high doses, and to remind people to take them the second dose earlier of an evening. If they're still having symptoms of withdrawal, so they may not be smoking, we would add NRT. That's a common thing to do. If they don't tolerate it, and this is usually the case in smaller people, so little women don't become nauseated by the Champix. If they get that, they can use half a dose, half a tablet, 1 tablet a day, 2 half doses a day. So think that through. There are certainly dose-related effects. We do know that bigger people might need a higher dose, more than actually the prescribed dosage. So do think about size and that it does matter. We also have, fortunately for us, because we have certainly told our pharmaceutical companies who make this, that they don't need to have a quit date, pick a quit date. We don't want this imperative on them that they need to quit at this particular time. We certainly want to say to them, this is how I put it, a quit date will pick you. If you're on Champix and you're getting less and less interested in smoking, people forget to smoke for hours on end, it's not reinforcing anymore, and it'll come to you. Yeah, I don't think I'll smoke today. And that's actually how it works, which is pretty cool and pretty good. This is just a flow chart about varenicline I wanted to show you, but I probably don't have time because I want to actually move on to some behavioural things. But you can have a look at this flow chart, if you like, later on, about how we decide when to add NRT and when not to. But it's basically, if it's working, it's great. If it's not working, forget about it. If it's half and half, add some NRT. That's basically what this flow chart's about. A little bit about Zyban before I go to some behavioural stuff, and that's to remind you that Zyban's metabolised to its active ingredient, to hydroxybupropion, and that's this CYP2B6 that does it. If you don't have that enzyme activating bupropion, it won't help you, it won't work. So I want to remind you that these are these genetic determinants. So if you don't metabolize to the active ingredients, you won't do well. Just wanted to explain that further. The the dilemma of e-cigarettes, you could obviously probably got the gist from me. Personally, I wouldn't be in favour of it. I don't recommend it. I'm looking at people who are severely addicted to nicotine, and this is a delivery device, as far as I'm concerned, that delivers nicotine in the same manner, inhaled. It's quite dependent producing. Is there evidence that it helps in smoking cessation? It's certainly not registered in Australia, and of course the College of Physicians is looking at it. Everybody is looking at the safety and efficacy of this. And in my point of view and my reading of the material, which I have a great deal, I don't want to reinforce nicotine in our smokers. We have manners and ways of getting people off it if we care to take or make an effort. Make an effort with your difficult patients, and you'll be able to see really excellent outcomes. So we'll see it as it passes along through the colleges, through our TGA potentially. We'll see where we go with e-cigarettes for the future. Of course, you don't want to start me on the tobacco industry and their involvement in it. Quickly to finish up, some behavioural advice based on evidence. What you could say, just say to patients who, if they're not doing this, here's the new house rule: everybody smoke outside. So you smoke, you don't smoke, you're using NRT, you're still smoking, you're on Champix, you're still smoking, whatever it is, as of today, here's this, you can say this, here's a script for your NRT, here's your script for that, but as of today, right, you can still smoke, but can you smoke outside? And it's a rule for everybody. Be consistent. You go outside to smoke, and we know that these are gateways. That's what it's called, a gateway to quitting. This includes the car. Some people already have the car as a no smoking. Oh no, this is my pristine zone and I won't smoke in my car. And I have no problem with that. But they have a problem with smoking indoors. So we want to change that, change the dynamics, be mindful of where you smoke, remind yourself that the environment where you smoke can be in itself a cue to smoke. The environment is a cue. This is where I do smoke. This is where I don't smoke. People are very compliant where they cannot smoke. Have you noticed that? We did some research on this a long time ago now, saying where you can smoke, you tend to want to smoke. Where you can't, you tend to not want to. So urges to smoke are sometimes predicated by the environment you're in. Hence, people do relatively well in hospital, but relapse as soon as they go home. This is where you can't smoke. This is where you can. So interestingly enough, make the no smoking home rule, and that'd be terrific. And that's a gateway. Avoiding other people's smoke, not the people, but the smoke itself. It's in itself. It's called proximal smoking. You breathe in somebody else's cigarette smoke, and people go, "Oh, I love standing behind somebody in the bus queue and us passively smoke." Passive active smoking. We don't want that, because that's a trigger to smoke. It's a stimulus. It's molecular. You're right, it's inhaling somebody else's cigarette smoke, you're getting the molecules, and we don't want that. That's a stimulus to the poor old neurons who are trying to get a shot of nicotine through the airways. Now, about throwing away cigarettes, keep in mind some people want to get rid of them. That's it, all the paraphernalia, throw it all away. And that makes some people extremely anxious. So you don't want that. But you don't want them too handy either. So some ideas about what you could do with your cigarettes. Simple ones like put them in the boot of the car. Easy. It means you make an effort to get them. They're here, but they're not here. You haven't thrown them away. So they're there, but they're not there. That's the idea. Some strategies like that really are very helpful. Acute urges to smoke. If you've got time to talk to smokers about imagining scenarios where they're going to be somewhere. Oh gosh, Friday night's going to be difficult because that's when I'm going to a party and everybody's smoking. What can I do? Imagining the scenario. This is called cue exposure. Exposing yourself to the cue in here, right? Practice imagining all the times and scenarios that you would have smoked, things that you did right, things that you did wrong. What can you do? We don't want people to avoid their real lives. We don't want them to avoid their friends who smoke. Just go places where you can't smoke. So go to the obviously the mall, go to the movies, go to the coffee shop, be somewhere where you can't smoke. See your friends. Don't avoid them, but do activities that where you know that there's no way that you can smoke, and you'll actually get used to, you'll habituate to being a non-smoker. That's what we want them to do. We want them to break up the pairing, cup of coffee in one hand, cigarette in the other, remembering it's not an orange juice in one hand and a cigarette in the other. It's coffee or alcohol. Break up the pairing, smoking outside, coffee inside. So breaking up the pairing. We do know one interesting little thing that helps, and that's short bursts of exercise with urges to smoke. Mimics a cigarette, increases your heart rate, gives you a little stimulus. And it's actually, there's good evidence for that. And using oral NRT. So if you feel like a cigarette, and I know I'm getting a bit of a wave from Christina, I think, to finish that, which I will do, and using oral NRT a lot. So I think in summary, your role is really very important in motivating and helping a smoker to quit, but without using the word quit, to manage them. Show them empathy and support and what it is that benefits them. Try to be non-judgmental about it. Please dispel some of the myths and misconceptions that are going on around, which really stymies the patients. Understand those liver interactions. Put the smoker in touch with cessation support. You don't have to do all the things that I was talking about. Our quit lines are very well versed in this, but do prescribe, recommend pharmacotherapies, and be proactive about it. Thank you very much.
Thank you, Renee, and I'm sorry to have interrupted you there. I was just getting conscious of the time, and we've had a few questions come in while you've been talking, and some of those I might pass on to you to answer afterwards, if that's okay, just because we probably won't have time to get through them all. But one in particular that has come through is asking whether or not you could comment on some patients who are presenting, who are smoking in their 80s, and also presenting with serious medical issues, and whether there are still known health benefits for smoking cessation at this age.
Well, it's a complicated one because you come across people, of course, like that, and we all do. And the ageing patient, I would rather see them in a form of NRT if they're going to use, nicotine. And sometimes they say, I'm so used to this, it helps me concentrate, it helps me function. And it might be nicotine. They're so neuroadapted. It's been millennia practically. It's been a long time they've been on nicotine, and it's is it too distressful for them to quit smoking? Will there be any health benefits? Certainly, they'll oxygenate better. Oxygen carrying capacity improves in absolutely everybody who's smoking age. So you're simply competing. If you think about it, carbon monoxide competes with oxygen, and when you smoke a cigarette, carbon monoxide always wins. Remember, it's highly dissolvable in hemoglobin. So everybody who smokes has carbon monoxide competing with oxygen. Everybody who smokes hemoconcentrates because of it. So their hemoglobin is higher and it'll concentrate. So unfortunately, fortunately for us, they will physically improve. And it makes a difference to them. Whether psychologically that's distressing for them, that's the component that's very difficult to address. You can recommend oral forms of NRT, the sprays, the inhalers, just to tell them that this will make you feel as if you've smoked but you haven't, and it'll reduce those other components that are really quite serious and deleterious to you. So that's how I would address it and do address it.
Okay, thank you. It's quite a tricky one.
Yes.
Okay, so thank you so much for that. And I know that it's now 8:30, so we'll be wrapping up. But just to let everybody know that we'll be making the video recording and handouts of these slides available tomorrow at the link on screen there. And as I mentioned, if you are attending live, you can claim CPD points against this activity by completing the evaluation. The link to do that is on screen. This was the final presentation in our series of alcohol and other drugs. So I just wanted to thank Sydney North Health Network for funding these, and thank all of our fabulous presenters throughout the series, and also let you know the rest of the webinar series can be accessed at the same link on screen there. And finally, thank you very much for joining us tonight, and thank you so much, Renee, and I hope you all enjoy the rest of your evenings.
Thank you.
Good night.
Good night.